Hello, everyone. Welcome to Journal Club. We're back to Thursdays now. Hopefully, a little back to our routine. But thank you for jumping on. Why don't I go ahead and record today's session so that we'll have it recorded for posterity's sake. And thank you for jumping on to our April 2nd Journal Club. Before we get started, I would like to remind you that we have a conference coming up. April 24th is the Pulp Med Conference. You can come here in Denver at the Denver PPA Event Center or join us online. We are going to live stream the whole thing. We can't live stream, the food and stuff like that, but you will get your CME if you join us online. And if you don't know how to register, please let me know. I will put the link in the chat box. And at this time, we'll go ahead and start Journal Club. So today our host is Dr. Greg Gum.
Oh, you were waiting for me. I was waiting for the main event. I'm going to have probably a few things to share at the very end, but Dave Shepard did this topic for us 2 years ago this month, um, and did such an outstanding job that I did not want to embarrass myself by trying to do this instead. So Dave has put together just a wonderful presentation for us. And I think if we share the screen, he has some slides for us. And I would encourage everyone to, number one, pay attention, but number two, ask questions. If this were simple, we would all get it right all the time. It's not. It is like diabetes. It is really complicated. So ask questions. Dave?
Okay.
That was when she was coming over.
Let me,
Okay. She kind of got here and we realized it.
Oh, and remember everybody to mute your line if you're not the speaker.
can you guys see that okay?
Yes.
Okay, excellent. So thank you guys. So I'm going to talk today about antiplatelet agents and anticoagulation. And I've tried to structure this a little bit differently. So we're going to start with a little bit of pathophysiology related to primary hemostasis and secondary hemostasis. And hopefully I won't trigger too many medical school coagulation cascade traumas here. But we're going to talk about antiplatelet agents and anticoagulants. And I kind of make a distinction between those two things for functional purposes, because I think it helps us understand what we're treating and why we're treating various disorders. So antiplatelet agents act primarily on primary hemostasis, on the development of a platelet plug in an artery. This is a fast action that happens really rapidly. Leads to the formation of a white clot that is full of platelets, and we use this as a therapy primarily for acute ischemic events and stroke and heart attack. In contrast, anticoagulants work on the coagulation cascade on secondary hemostasis. And I think about secondary hemostasis in conditions like DVT and atrial fibrillation, where things happen a little bit slower over time. And so here's probably the triggering slide. I still remember 1211 98 10521. I can't remember what my wife's phone number, but for some reason I remember most of the clotting factor numbers. Initially we have the primary platelet hemostasis, which is a platelet plug forming, and that is it happens very quickly. I primarily think of it in the arteries. It does happen everywhere, but I think about it in the arteries initially. A coagulation cascade is secondary hemostasis. It is a slower process. And I think about secondary hemostasis as thrombus formation in the veins. And the medications that we use in those conditions are apixaban and rivaroxaban and dabigatran,
Okay.
direct 10A inhibitors, apixaban and rivaroxaban, and then dabigatran, which we probably don't use as much, but it's a direct thrombin inhibitor. That's factor 2A. And then warfarin, which inhibits multiple clotting factors, 2, 7, 9, and 10. So kind of just to summarize, antiplatelet agents like aspirin and clopidogrel and other P2Y12 inhibitors such as clopidogrel act on primary hemostasis, and that is platelets and platelet plugs. And we use these therapies in arterial clotting conditions primarily, such as MI and stroke. And anticoagulants such as DOACs and warfarin act primarily on secondary hemostasis, on the coagulation cascade. And we use these in primarily in venous clotting conditions like pulmonary embolism, atrial fibrillation, DVT. So this is just kind of outlines what happens in primary hemostasis. So just to summarize it quickly, you have some kind of an arterial endothelial injury that leads to vasoconstriction initially. And then a platelet will come along and find that injury and bind to von Willebrand factor and adhere to that injury. It will become activated, and then you'll see the platelets become sticky, and you'll have platelet aggregation over the injury, and you'll form a platelet plug. This is often called a white clot. In venous clotting, which is secondary hemostasis, this happens primarily in areas of low flow, low blood movement, right? Areas of stasis. And you may see maybe a local increase in the concentration of clotting factors in some of these areas. You may also have hypercoagulable states like malignancy or factor V Leiden or PT gene mutation or some other genetically inherited hypercoagulable state. But you'll also have some kind of an endothelial damage, whether it's from a catheter or inflammation or some kind of a trauma that will trigger the clotting factors to activate. And they'll trigger thrombin formation, fibrin formation, and they'll start to develop this venous clot. And you'll see red blood cells get entrapped in this venous clot. And this is sometimes known as a red thrombus. So I'm a simple guy, so I like analogies. And for me, the analogy here is that the platelets are like the bricks, and the coagulants are like the mortar that stabilizes the bricks. I find that useful to kind of keep track of what's going on with these medications. So there's really three things we're going to discuss. And in the venous system, we're going to talk about coagulation as it relates to atrial fibrillation, mechanical valves, and things of that nature. And we're going to treat that with full dose anticoagulation. Now that's in contrast to endothelial injury in the arterial system, which will lead to a platelet plug, like we see in stroke and MI and maybe peripheral artery disease as well. And we treat that with antiplatelet therapy. So we're targeting two different mechanisms here. What I'm not going to discuss today is peripheral artery disease, where you may see, you may need dual pathway inhibition. It seems to be much more of a mixture of those two different etiologies. So we'll start with the role of anticoagulation and antiplatelet agents in stroke. Just as a reminder of several types of stroke, right? But we can break them down into maybe three different buckets. There's large artery atherosclerosis, where we have atherosclerotic plaque that ruptures, the platelet comes in, forms a platelet plug, you get vasoconstriction, and you get an ischemic event. We treat those with, initially anyway, with dual antiplatelet therapy, and then we transition to single antiplatelet monotherapy. For cardioembolic stroke, which we see in LV, in atrial fibrillation, where the LV thrombus, or the left atrial appendage forms thrombotic emboli. You may see this in mechanical valves as well. We treat that primarily with anticoagulants. And then there's this cryptogenic stroke, which we used to think was related to unrecognized atrial fibrillation, but it turned out that that's probably not true. At least anticoagulation didn't particularly help that. So we've moved towards treating it with aspirin as single antiplatelet therapy. There are new guidelines as of this year for management of acute ischemic stroke. And I've put them in there for you to read the synopsis, but basically for non-cardioembolic ischemic stroke, triple antiplatelet therapy has no benefit. Anticoagulation has no benefit and increases bleeding risk. And for minor acute ischemic stroke or high-risk TIA, 21 to 90 days of dual antiplatelet therapy followed by monotherapy with an antiplatelet agent is beneficial. And continuing dual antiplatelet therapy beyond 90 days is not beneficial and actually may increase bleeding risk. So dual antiplatelet therapy efficacy for acute stroke is optimal within this 21-day time span. It used to be 21 to 90 days, but now the guidelines are really starting to lean more towards the 21 days. After 21 days, the efficacy drops, bleeding risk increases. There are now several large studies supporting this 21-day optimal period. There's no benefit of oral anticoagulation over antiplatelet therapy. And the reality is antiplatelet agent choice is primarily driven by cost in my experience. So just to summarize, for non-cardioembolic origin stroke, the treatment pathway is typically dual antiplatelet therapy for 21 to 90 days, followed by monotherapy for secondary prevention. For cardioembolic stroke, we're going to end up on oral anticoagulant monotherapy as well for secondary prevention. And addition of an antiplatelet agent is rarely needed. Long-term dual antiplatelet therapy does not seem to further reduce the risk of stroke recurrence and increases major bleeding. So there's a lot on this slide, and there's a lot about how you treat particular circumstances with stroke. And really what I want you to take away from it is that you'll notice on the right side here, all of these end in some type of monotherapy, whether it's oral anticoagulant monotherapy or oral antiplatelet therapy. After about 90 days, we need to start thinking about what monotherapy should this person be on post-stroke. So now we're going to talk about anticoagulation and antiplatelets as it relates to acute coronary syndrome and stable coronary artery disease. And the recommendations for dual antiplatelet therapy in ACS are, to say the least, nuanced, right? This is where I think we all get a little confused in what agent to use and for how long after PCI. The default recommendation seems to be 1 year of dual antiplatelet therapy after ACS in patients without high bleeding risk. And I don't know that I have many patients that are without high bleeding risk, but that's something to take in consideration. So after about 12 months of dual antiplatelet therapy, I need to start looking to decide if single antiplatelet therapy is what I should be moving towards, using clopidogrel, aspirin, or ticagrelor. And ticagrelor is sneaking into our guidelines more and more, especially the cardiac guidelines. It may have a little lower bleeding risk, I think. I don't know if expense is going to be an issue, but it's starting to pop up in very specific places where it's being studied. So I think we may see more ticagrelor being used. In patients who were previously on anticoagulation, long-term combination anticoagulation and antiplatelet therapy really is not necessary. You can perform some kind of a step-down monotherapy after about 6 to 12 months, even in patients post-PCI. And patients with stable coronary artery disease, if you start an anticoagulant on those patients, you can stop the antiplatelet agent. Of course, this needs to be individualized. There's always going to be exceptions to these kind of rules. But we now have accumulating data on the safety and efficacy of shorter dual antiplatelet therapy duration. And it's starting to make our way into our cardiac guidelines as well as our stroke guidelines. So just to recap the basics for stable coronary artery disease, we're going to end up at antiplatelet monotherapy of some kind. For medical management of acute coronary syndrome, we typically will follow a path of either dual antiplatelet therapy or triple therapy with low-dose rivaroxaban, aspirin, and clopidogrel. I'm not sure how much I've actually seen that done in my practice, but after about a year of one of those, we typically will step down to aspirin monotherapy. And in patients who have had acute coronary syndrome and percutaneous coronary intervention, There, typically, we're going to use some kind of a dual antiplatelet therapy for, this probably should say 0 to 12 months, because this is where it gets nuanced. There's various ways to use the antiplatelet agents and various antiplatelet agents to use within that 12-month period. However, once we get out of that 12 months, we're going to land on some kind of a single antiplatelet monotherapy. And in patients who were previously on anticoagulation, who have percutaneous coronary intervention, it's typically going to start with therapy with 6 to 12 months of some kind of a triple therapy with dual antiplatelet therapy and oral anticoagulation. And then there's a stepwise de-escalation to oral anticoagulant monotherapy. So there are a couple of recent studies about bleeding risks that I wanted to throw in here. One's from 2025. It is a French study, double-blind, randomized, placebo-controlled trial comparing oral anticoagulation plus aspirin to oral anticoagulation with placebo. So combination therapy with oral anticoagulation monotherapy. And it was stopped early due to excess of deaths. It was stopped at about 2 years because of excess deaths in the combination group. Major bleeding in the aspirin group was about 10.2%, and the placebo group was about 3.4%. It's never a good thing when your study is stopped early because your study group has increased major bleeding. And another recent study from February that looked at therapy for AFib in patients with drug-eluting stents, and this was a non-inferiority trial comparing oral anticoagulant plus clopidogrel to oral anticoagulant monotherapy alone. And it found that monotherapy was non-inferior to combination therapy, and it also found an increase in bleeding risk in the combination therapy group. So combination therapy certainly does increase our bleeding risk. And this is a complicated slide, right? This is for patients who have an indication for oral anticoagulation and then undergo PCI, for acute coronary syndrome. Maybe they had AFib or pulmonary embolism prior to their acute coronary syndrome. And in these patients, we need to take into account their thrombotic risk as well as their bleeding risk, which means there are at least 4 permutations to consider. There's probably more than that. Really, what I want you to take away from this is that these all end in some kind of a transition to oral anticoagulant monotherapy. We're going to use triple therapy with aspirin, clopidogrel, and an oral anticoagulant for 1 to 4 weeks, depending on the situation. Then we'll move to double therapy with clopidogrel and an oral anticoagulant for 6 to 12 months, depending on the situation. And after 12 months, we will land, for most people, land on oral anticoagulant monotherapy. So just to summarize, in stable CAD, we primarily will treat that with aspirin, with single antiplatelet monotherapy. You may want to use ticagrelor or clopidogrel. There may be other reasons to use those agents, but single antiplatelet monotherapy is primarily where that is going to land. In patients who have had heart attack and PCI, going to use dual antiplatelet therapy for 6 to 12 months, some permutation of dual antiplatelet therapy. The cardiologists kind of get to drive that. But at the end of that, we, for the most part, will land on single antiplatelet therapy. In medical management of acute coronary syndrome, we will use dual antiplatelet therapy or triple therapy with low-dose rivaroxaban, aspirin, clopidogrel. And after that, typically you'll transition to aspirin monotherapy. And then, as we just discussed, in patients who have AFib or pulmonary embolism, pre-existing reason to be on an anticoagulant, who have a heart attack and undergo PCI, they're going to be on triple therapy for 6 to 12 months, and then some kind of a stepwise de-escalation to an oral anticoagulant monotherapy. So it gets complicated, right? Especially for the cardiac indications for antiplatelet therapies. For me, The way I think about it is, a patient has an acute coronary syndrome. They get a PCI, maybe they don't get a PCI, but for 6 to 12 months, they're going to be on some combination of antiplatelet therapy, whether it's dual antiplatelet therapy with or without an anticoagulant. But after 12 months, most of these people can be transitioned to either a single antiplatelet therapy or an oral anticoagulant monotherapy. There's always going to be exceptions. That's when we'll need to get together with our cardiology colleagues and put a plan together and outline it in our notes. But most roads lead to either antiplatelet monotherapy or anticoagulant monotherapy. And so I think it's important that when we see our patients, we review their meds, we look for instances where people are on more than one agent. Maybe they're on 2 antiplatelet agents. Do we really need that? Where are they? Why are we doing it? Where are they in the timeline? Is it beyond 90 days if it's a stroke? Is it beyond 12 months if it was acute coronary syndrome? Is there a good indication to continue both of them? I think when we read our medication list, if we see more than one anticoagulant on there and an antiplatelet agent, it probably needs to trigger us to think about whether or not that's a good idea, because it certainly does raise their bleeding risk. And most of our patients are already at high bleeding risk to start with. And I think that's it for me. All right.
Yeah, thank you, Dr. Shepard. As you were presenting, I double checked from our March Journal Club where Dr. Eber and myself presented on secondary prevention in ischemic stroke and the approach to peripheral artery disease. And everything you said today was very consistent with what those resources suggested as well.
Awesome. Thank you.
And I was wondering, in these cases where they recommend a single antiplatelet agent, is there any reason to pick aspirin over clopidogrel or vice versa?
Clopidogrel is the choice now.
Yeah, in some cases, ticagrelor is going to be your choice. And so, to be honest with you, I would have to look it up. Obviously, the agent that you're going to be able to afford and that you're going to take is the one you may have to go with. Aspirin is certainly cheap. And so for stroke indications, you see it used a lot. I don't know if we have moved towards using clopidogrel post-stroke or not. I think some people have. But yeah, I would have to look that up. I'm not sure I can give you a hard, fast rule on when to use each of these agents for monotherapy.
Yeah, Dave, I read there was a recent editorial in Cardiology about that there's a more of a move toward Plavix now that it's generic and it's not that much more expensive than aspirin. So I think we'll see a lot more of that. One of the things I was going to point out, and so I'll just wrap up real quickly. The things I was going to share, 2 things. One is the comparison of Eliquis to Xarelto. And the Beers report from 2 years, 3 years ago now almost preferred Eliquis to Xarelto because of bleeding. And there was the Cobra trial recently came up with the same answer. So that would be my one comment about on the summary slide where they were using the rivaroxaban. For our patients, we should probably be using Eliquis.
Yeah.
And then the only other thing I was going to throw in, since it looks like we have time to wrap up today, is to just keep your eyes open for the factor 11A inhibitors. So asundexian looks like in the trials less bleeding than the DOACs, and at least through the phase 2 trials and early phase 3, maybe even more effective than the DOACs. So I think that Eliquis and Xarelto will be a thing of the past, at least academically, within 2 or 3 years.
Okay. Does anybody know the cost on ticagrelor? Is it generic at this point or not?
Let me see. Yeah.
Hey, Dave, Leannenberg here.
Yeah.
Is there ever a valid reason to use warfarin for anything anymore?
I think we're stuck with it for mechanical valves and antiphospholipid antibody syndrome, right?
Right. Yeah, those were the two I was thinking of. And then on the dose of the aspirin, in Europe, some of their studies use 100 milligrams, and we have 81 and 160 or 162. What dose of aspirin is most commonly used when it's the drug of choice?
Yeah, so that's kind of controversial when I went to look that up. The sources I found did not favor a dose. They favored a lower dose, actually, because they're going to have lower GI side effects with a lower dose, right? You get the platelet inhibition with maybe without the gastrointestinal bleeding concern. So for me, I favor a lower dose. I don't know that anybody, and please correct me if I'm wrong, I'm not sure that anyone has made a good argument to use high dose aspirin 325s.
No.
Yeah, and final question for me is the SSRI family are drugs that inhibit serotonin reuptake. And platelet aggregation is dependent upon the release of serotonin for the platelets to become sticky and aggregate. So there are increased GI and cerebral bleeding risks just from SSRIs alone. And when they're used with aspirin or the other antiplatelet drugs, the risk goes up even more. So that's not often addressed in articles and discussions, but it is a real phenomenon.
Yeah, I looked at that a little bit because I've talked about that in various coffee meetings. So most of the studies have been observational, so we don't have great data on it, at least from what I was reading. But theoretically, it is a concern. Certainly, when you have more than one agent acting on, any platelet pathway, they can be synergistic, right? But most of what I found thought that it wasn't clinically significant, although it doesn't look like we have great data to be able to say that. So I think you need to take it into consideration. I think a couple of the antipsychotics like risperidone also can affect clotting or platelet activity as well.
Dave, Tacag, however you pronounce it, Ticagrelor,
Yeah.
on GoodRx, $33 a month.
Okay. Yeah, so it's going to get cheaper, and I suspect we're going to see more and more of that being used. I've seen it pop up already in places, and I've kind of not understood why, but in very specific indications, I think it's getting more use.
Yep.
I copied the prices for ticagrelor versus Brilinta in the chat box from Up to Date.
Oh, thank you.
Mm-hmm. I mean, you just
Thank you for sharing.
the lady was kind of that.
Okay. That's it for me. Greg, anything else?
I don't have anything else. Questions, anybody? Input? Yeah, I guess the last thing I'd leave with is just keep an eye out for aspirin use for primary prevention. Maybe in diabetics. There's at least one or two trials showing that it's probably beneficial there, but non-diabetics, just don't do it.
No, and there's several guidelines now that kind of are saying the same thing. U.S. Preventive Services Task Force, ACC, AHA, European Society. Canada basically just recommends against routine use regardless of age and diabetes. So I think you really want to think about it, especially knowing the bleeding risk of aspirin is not as low as what we thought it was.
Yeah. Oh, thank you, Travis. Manufacturer coupons. You can get that Brilinta down to $5 a month.
Okay.
Skip Starbucks one day.
All right.
Well, thank you so much. Great journal club, good discussion. Please send any further questions to Dr. Shepard so we can get them answered. And don't forget to register for the annual conference. I put the link in the chat box again.
Good.
Thank you, everybody. Have a good day.
Thanks, everybody.